Hi guys, welcome back. Today we'll be talking about acid-base regulation. So what is an acid? Acid is a substance which releases H+. HCl is one example. And base, which accepts that H+, hydroxyl ion, sodium hydroxide is one example. What is the normal blood pH? So arterial blood pH is around 7.35 to 7.45. And anything less than this is called as acidosis, and anything more than 7.45 is called as alkalosis. And to maintain this pH at a constant range of 7.4, our body has three defense mechanisms called as buffer systems. One is called as chemical buffer, two respiratory buffer, and three renal buffer. Chemical buffer acts within seconds and it is called as first line of defense. And respiratory buffer acts within minutes, second line, and hours to days is by renal, and that is the third line of defense. So coming to the chemical acid base buffer system. So what is a buffer? Buffer is a substance that reversibly bind with H+. So if the concentration of H+ is more, the reaction favors this direction. If the concentration of H+ is less, the reaction favors this. So that is a reversible reaction. So in our body per day around 80 milliequivalents per liter of H+ is produced, or we ingest that. But only the plasma H+ is around 0.004 milliequivalents per liter, and urinary H+ is 0.03 milliequivalents. Where is this 80 milliequivalents? So this 80 milliequivalents is excreted with the help of buffers. So why that is required, we'll see in the next slides. So there are three main chemical buffers. One is bicarbonate, two is phosphate, and three is protein. Coming to the bicarbonate buffer, it has a component of a weak acid, that is carbonic acid, and a salt, sodium bicarbonate. So carbon dioxide will be mixing with water to form carbonic acid under the influence of an enzyme carbonic anhydrase, and which can dissociate into H+ and bicarbonate. So depending upon the concentrations, the direction varies. So let us think that we add a stronger acid to this bicarbonate buffer. So this acid binds with the bicarbonate and it forms a weaker acid, carbonic acid, which splits into carbon dioxide and water. This carbon dioxide is eliminated through respiratory system. So the change in pH is corrected. Similarly, a strong base is added that fuses with the weak acid, carbonic acid, to form sodium bicarbonate, which is a salt which doesn't alter any pH. So in this way, bicarbonate buffer acts. So the dynamics of this bicarbonate buffer is explained by an equation called as Henderson-Hasselbalch's equation, where pH is equal to pK plus log bicarbonate by carbon dioxide into 0.03, that is a soluble coefficient, and this pK for bicarbonate buffer is around 6.1. Even though our blood pH is around 7.4, the pK is 6.1, which is a bit away from this value. Even though it is away from that, it is a powerful extracellular buffer because bicarbonate and carbon dioxide are precisely regulated by kidney. Bicarbonate is regulated by kidney and carbon dioxide is handled by lungs, and bicarbonate is also in large quantities in extracellular fluid. That's why it's a powerful extracellular buffer even though its pK value is 6.1. Phosphate buffer system, which contains sodium dihydrogen phosphate and disodium hydrogen phosphate. A strong acid is added which reacts with disodium hydrogen phosphate to form a weak acid, sodium dihydrogen phosphate, and a sodium chloride. Similarly, sodium hydroxide is added which fuses with sodium dihydrogen phosphate to form a weaker base or a salt, that is disodium hydrogen phosphate, and its pK value is 6.8, but it is a weaker buffer in extracellular fluid because of its low quantity. but it is a good buffer in tubules of kidney and intracellular buffer where its pK value is nearer to the intracellular pH. Proteins. Proteins also will be having a pK value nearer to the intracellular pH and they are good intracellular buffers. One such example is hemoglobin. Hemoglobin temporarily binds with H plus and whenever its quantity is reduced, H plus is released. And coming to the respiratory regulation, which is second line of defense, which occurs within minutes, around 3 to 12 minutes, and usually whenever the carbon dioxide levels are increased, they are detected by the chemoreceptors, and this chemoreceptor stimulates the respiratory centers and that causes hyperventilation. So that extra CO2 is washed out, and these are having 1 to 2 times more buffering action than the chemical buffers. So increased ventilation causes washout of CO2, that causes increase in pH. Coming to the renal control, which is the long-term mechanism, and it is primarily managing the non-volatile acids. Volatile acids are managed by the respiratory system. Non-volatile acids, how it manages that? Either it excretes a urine which is rich with H plus or it excretes urine which is more with bicarbonate. So usually around 4320 milliequivalents of H plus is secreted to reabsorb same quantity of bicarbonate. So kidney is exchanging bicarbonate with H plus, but we said there is 80 milliequivalents which is produced additionally that should be handled. So totally kidney is handling around 4400 milliequivalents per day. Kidney handles the changes in pH by either it secretes H plus, reabsorbs bicarbonate, or it produces new bicarbonate. Let us think that there is alkalosis where there is less H plus. So for bicarbonate reabsorption, we require H plus to be secreted. As the H plus is low, all the bicarbonate is not reabsorbed and simply it is excreted. So simply kidney is excreting alkaline urine. In acidosis, let us think that there is increased H plus. So all the bicarbonate is reabsorbed and H plus is still available. So it also causes new bicarbonate synthesis. This is how kidney handles. We'll go into the details in the next slides. So for every one bicarbonate that is reabsorbed, one H plus should be secreted. This occurs in the proximal convoluted tubules around 80 to 90%, and 10% occurs in ascending limb and remaining DCT, CT. Even though the CT holds very low percentage of handling of H plus, but it has higher capacity to change the pH of the urine. Okay, so now the bicarbonate is filtered into the tubular lumen. Now this bicarbonate will be united with H plus to form carbonic acid. This carbonic acid can't cross the luminal side membrane, so it dissociates into CO2 and H2O. The CO2 crosses that, fuses with H2O with the help of carbonic anhydrase, again forms carbonic acid which dissociates into HCO3 minus and H plus. So this HCO3 minus is reabsorbed and H plus is secreted out. So for every bicarbonate that is reabsorbed, we are getting one H plus to be secreted. Similarly, in DCT and CT, H plus is secreted into the lumen and bicarbonate is reabsorbed. Here primarily H plus is secreted as primary active transport. So in early tubules, reabsorption of bicarbonate is occurring. So 432 milliequivalents of bicarbonate is reabsorbed with secretion of 4220. So this excess 80 is excreted in urine in combination with phosphate and ammonia buffers. Why in combination? If not in combination, to excrete this, we require so much of water. So we'll see. The combination of excess hydrogen ions with phosphate and ammonia buffers occurs. So usually at a pH of 4.5 of urinary pH, only there is 0.03 milliequivalents per liter is excreted. But we require how much to be excreted? 80 milliequivalents. So to excrete 80 milliequivalents, 2667 liters of urine is to be excreted. So to prevent this excess water loss, that 80 milliequivalents is handled by ammonia and phosphate buffers, which are titratable acids. Coming to the phosphate buffer, as we said, it is having a pK of 6.8, which is nearer to the tubular pH, and extra H plus will bind with hydrogen phosphate to form dihydrogen phosphate, and this dihydrogen phosphate is excreted in urine, and the maximum of 40 milliequivalents per liter is handled with this. So for every 1 H plus secreted, 1 bicarbonate is newly synthesized. So hydrogen phosphate is filtered in the tubular fluid, that fuses with the H plus secreted, and this dihydrogen phosphate is excreted in urine. For this dihydrogen phosphate, we got 1 new bicarbonate synthesized. So for every bicarbonate synthesized newly, we are secreting 1 H plus, which binds with sodium hydrogen phosphate to form sodium dihydrogen phosphate. So coming to the ammonium buffer system, there are one ammonia and ammonium. So whenever there is H plus concentration more in the tubular lumen, that stimulates the glutamine metabolism, which causes generation of 2 new bicarbonates and 2 H plus secreted in the form of 2 ammonium. So 50% of H plus is eliminated by this ammonia buffer system. So whenever there is H plus more, glutamine metabolism occurs, and that causes 2 new bicarbonate synthesis and excretion of 2H plus in the form of ammonium ions. So in collecting tubule, H plus is secreted into tubules and it combines with the ammonia to form ammonium ion. So 1 new bicarbonate. So with the glutamine we are getting 2 bicarbonates, but with ammonia, so filtered ammonia in collecting tubules causes binding of H plus to form ammonium, and this is excreted out, and we are getting 1 new bicarbonate. Coming to the acid base disorders, as we already know, pH is equal to 6.1 plus log bicarbonate by PCO2. So the ratio of bicarbonate and PCO2 decides the pH. So if the ratio of bicarbonate by CO2 increases, that means either bicarbonate is increased or carbon dioxide is lowered, that causes alkalosis. If the ratio of bicarbonate and CO2 decreases, that means either bicarbonate decreases or PCO2 increases, that is called acidosis. Now we'll go individually. So fall in base of, that is bicarbonate, will cause metabolic acidosis. Increase in carbon dioxide is called as respiratory. So here two substances are there, one is CO2 and one is bicarbonate. If anything increases CO2, it is called respiratory acidosis. If anything decreases CO2, it is called as respiratory alkalosis. If anything increases bicarbonate, it is called metabolic alkalosis. Anything which decreases bicarbonate, it is called metabolic acidosis. So we'll talk about metabolic acidosis. It's of two. One is increased acid, either diabetic ketoacidosis or lactic acidosis, or decreased bicarbonate. So diarrhea or type 2 renal acidosis. So in metabolic acidosis, there is a term called as anionic gap. So usually cations is equal to anions. So primarily we are considering sodium, bicarbonate and chloride, and there might be some unmeasured anions like proteins. And anion gap is equal to the difference between sodium, bicarbonate and chloride. So normally it is around 12 plus or minus 4 milli equivalents per liter. So sodium is equal to bicarbonate plus chloride and non-diffusible or non-measurable anions. So let us think that if there was an addition of an acid. So whenever there is an addition of an acid, the chloride won't change and it becomes normochloremic metabolic acidosis. Usually addition of acid like keto bodies, lactic acidosis or salicylate poisoning, which is aspirin poison. But let us think that where there is loss of bicarbonate. So to compensate that, the chloride levels increases. So that's hyperchloremia, and the anion gap will remain normal, which is seen in diarrhea, renal tubular acidosis and carbon anhydrase inhibitors where bicarbonate is lost. Now coming to the compensatory mechanisms. So what we said, metabolic acidosis. Metabolic acidosis is nothing but decreased bicarbonate. So decreased bicarbonate is favoring the fall in pH. So whenever there is a decreased bicarbonate in the plasma, its filtration reduces. So complete bicarbonate reabsorption occurs, still some H plus is left out, excess, and this excess is excreted by our ammonium and phosphate buffers, and which also favors new bicarbonate synthesis. Coming to the metabolic alkalosis. Metabolic alkalosis is simple. Either you are adding bicarbonate or you are removing H plus. So ingestion of antacids. So for gastritis we use antacids. If it is overused, that can cause addition of more base. Removal of H plus. Vomiting from the stomach, which causes loss of H plus, and hyperaldosteronism, which causes excessive loss of H plus. So how this compensated? So here metabolic alkalosis is increased bicarbonate, and in that direction pH is altered. So if there is more bicarbonate filtered, so excess tubular HCO3 is there than H plus. So H plus is not sufficient to reabsorb, so it is excreted, which leads to excretion. And also, as there is no more new bicarbonate synthesis, so no more H plus secretion. Respiratory acidosis. Respiratory acidosis is nothing but increased pCO2. Usually occurs when there is depression of the respiratory centers when used a sedative or opiate, or weakness of the respiratory muscles, or any obstruction to airway, or impaired diffusion of the gases. All these causes respiratory acidosis. So in that, the criteria is increased carbon dioxide, which is favoring the fall in pH. So whenever there is increased pCO2, that causes more generation of H plus. So if there is more H plus, more will be the bicarbonate excretion, and still some H plus is left, and this H plus is handled by ammonium and phosphate buffers, which causes new bicarbonate synthesis. Respiratory alkalosis, where excess CO2 is washed out. So CO2 is washed out, that leads to decreased CO2 and psychogenic hyperventilation, aspirin poisoning and high altitude. So how the kidney handles this. So decreased PCO2, so decreased H plus formation. So now H plus is low in the lumen, so less bicarbonate is reabsorbed. So more bicarbonate is there, so more bicarbonate is excreted, and no new buffers, so less H plus excretion. So how will you determine whether it is a compensated or not? So first check the value pH. Is it less than 7.4 or more than 7.4? First we'll go with the less than. So less than 7.4, and it is having, we call that as acidosis. And remember two values, 24 milliequivalents per liter bicarbonate and CO2 40 mmHg. Now the next step is, if bicarbonate is low, we call that as metabolic acidosis. If CO2 is more, we call that as respiratory acidosis. Okay, now compensation. So if there is acidosis, so respiratory compensation is simply hyperventilation. So if there is hyperventilation, CO2 is washed out and its value goes less than 40. And now if PCO2 is there, so that is called respiratory acidosis, and the renal compensates that by excreting, by reabsorbing the bicarbonate. So bicarbonate value will be 24 milliequivalents. So we'll take this example. pH is less than 7.4 and PCO2 is greater than 40 and bicarbonate is 24 milliequivalents. So if we individually look at the bicarbonate, which is more, we might say it as alkalosis, metabolic alkalosis. But the pH is towards acidosis. So pH is acidosis and the pH is favoring the increased PCO2. So here this is the change that caused the pH to fall, and this is the compensation occurred. Okay, now we'll go for the increased pH. So more than 7.4, it is called alkalosis. So first, if the rise is due to bicarbonate rise, we call that as metabolic alkalosis, or if it is due to fall in CO2, we call that as respiratory alkalosis. So metabolic alkalosis is compensated by hypoventilation that causes accumulation of CO2, so CO2 value increases. And alkalosis, if it is due to CO2 fall, that is compensated by excretion of bicarbonate, so less than 24 milliequivalents. So we got bicarbonate reduced, so pH is counterly corrected. So increased pH counterly corrected to decreased pH. So this is how to analyze a ABG sampling. So to summarize, we have three buffer systems. One is chemical, one is respiratory, another one is renal. So chemical buffer occurs in seconds and mainly bicarbonate, phosphate and protein. Out of this, bicarbonate is the strongest extracellular buffer and phosphate is strongest intracellular and renal tubular buffer, and protein is intracellular buffer. Respiratory is simple hyperventilation or hypoventilation. Renal is one, bicarbonate reabsorption, H plus secretion, new bicarbonate synthesis. I hope this is clear. Thank you for your patient listening. Bye.